Nathan, for that only mildly hyperbolic introduction. Again, my name is Julian, and I'm going to be talking today about some of the work that we've been doing on myocardial infarction in Tanzania. I want to start by acknowledging that the work that I'm going to talk to you about today is the result of a lot of effort by a lot of people, and so I want to acknowledge our team of collaborators here at DGHI and at KCMC. I'm noticing that I left Janet Becker's name off this list, but she should be on this slide as well. In terms of disclosures, Abbott Laboratories donated the point-of-care troponin supplies that were used in the study I'm going to talk to you about today, but beyond that I have no disclosures. So today we're going to talk about what's currently known about a myocardial infarction in sub-Saharan Africa. That will be very brief because very little is known. And then we're going to summarize the findings of our research project and talk about some future directions for research. Some brief terminology for those of you who do not have medical backgrounds. Myocardial infarction, or MI, and acute coronary syndrome, or ACS, are the medical terms for a heart attack. And throughout this presentation, I'm going to use the terms MI, ACS, and heart attack interchangeably. A heart attack occurs when a blockage in a blood vessel causes decreased blood flow to the heart, and some heart cells die. The most common symptoms of an MI are chest pain and shortness of breath, and one of these symptoms are present in the vast majority of patients who have an MI. An MI is typically diagnosed by an electrocardiogram or an ECG, which I have pictured here. It's an electrical tracing of the heart, and a blood test for cardiac biomarkers called troponin. That is literally everything you need to know from medical school to understand the rest of this talk. So MI is the leading cause of death and disability worldwide. We all know that cardiovascular disease is the leading cause of death worldwide. And within cardiovascular disease, MI is by far the most common cause of death and disability globally. But in sub-Saharan Africa, the burden of MI has historically been considered to be very low. So you can find these fascinating studies from the 60s where they did autopsies on a bunch of adult Africans who died, and they found that none of them had heart disease, which is kind of amazing given what was going on in the rest of the world. And this higher burden of a low burden of MI was thought to be due to the relatively high burden of communicable diseases like malaria, tuberculosis, HIV, and a much lower burden of MI risk factors. So historically, there was way less obesity, there was way less cigarette smoking, there was way less high blood pressure in sub-Saharan Africa. But as we all know, that has changed rapidly and drastically. And there's been a lot of data about this explosion in cardiovascular risk factors across sub-Saharan Africa. Obesity, high blood pressure, diabetes, even unfortunately, cigarette smoking. To take the case of Tanzania specifically, this slide kind of summarizes our best estimates of the current prevalence of a bunch of MI risk factors among adult Tanzanians and adult Americans. And you can see when it comes to high blood pressure, diabetes, cholesterol, obesity, there's really very little difference in the risk profile of your average adult Tanzanian and your average adult American in 2019. And so data like this has led a lot of people to assume that MI must be quite common or increasingly common across sub-Saharan Africa. And it's data like this that has led smart modelers to predict that MI is a very important cause of death in Tanzania. So this comes from the Global Burden of Disease Study, as you know, which uses a lot of modeling. And the Global Burden of Disease Study estimates that in 2016, ischemic heart disease, or MI, was the fourth leading cause of death in Tanzania. And in fact, the rapidly growing fourth leading cause of death in Tanzania. This data, of course, does not come from any data about MI in Tanzania because there's no data about MI in Tanzania. This data comes from looking at the prevalence of risk factors, modeling and extrapolating from what we've seen in other countries. And this is where the story gets really interesting because you're not going to find any study anywhere where MI is the fourth leading cause of anything in sub-Saharan Africa. So we did a systematic review of studies of MI in sub-Saharan Africa, and we found that there was almost no data about sub-Saharan Africa, which is in stark contrast to, say, the United States, where we can't stop studying MI. There's been almost no studies of MI in the entire region. And the few studies that have been done were small retrospective studies, and these suggested that MI was an extremely uncommon diagnosis. So in these small retrospective hospital-based studies, mostly in West Africa, they found that almost no one was being diagnosed with MI. And this is in stark contrast to what we've seen with stroke in sub-Saharan Africa. So stroke has been really, really well studied in sub-Saharan Africa, and we have a lot of studies to say that the burden of stroke in sub-Saharan Africa is high, it's growing, and in most parts of sub-Saharan Africa, the burden is already higher than in high-income settings like the United States. Stroke and MI share all the same risk factors, so this is kind of unusual. And the apparent scarcity of MI, coupled with the apparent large burden of stroke, has led a lot of smart people to conclude that in sub-Saharan Africa, the dominant form of cardiovascular disease is stroke and not MI. This would, of course, be in contrast to every other region in the world where stroke and heart attack are highly correlated, but heart attack is just more common in every other world region. And so there's been a lot of speculation about what is the explanation for this apparent absence of MI in sub-Saharan Africa. And some people have speculated that there must be something really unique and interesting going on, either in environmental factors or genetic factors or dietary factors, something that's preventing adult Africans from getting heart attacks without preventing them from getting strokes. Other people have said it's probably nothing unique. We're probably just missing all the MIs. Maybe patients aren't coming to the hospitals. MI is a tougher diagnosis to make. Maybe the doctors are missing it, so it's probably just being missed. But there isn't actually a lot of data to support either of these theories, and more importantly, there's really not a lot of data at all about MI in the entire region. So the aims of our research program have been to describe current patterns of MI diagnosis and care in northern Tanzania, to understand community perceptions of MI in northern Tanzania, and to quantify the quantify the burden of MI in an emergency department in northern Tanzania. Our research program has consisted of a lot of different parts, and I'm going to talk to you about 5 of those parts today. A retrospective chart review, a community survey, a prospective observational study in an emergency department, a qualitative study, and a continuation of the prospective observational study with MI testing. So our setting is KCMC, which most of you hopefully have heard of. It's one of DGHI's priority sites. It's a large referral hospital in northern Tanzania, and the emergency department is pictured here. The community survey that we performed was performed in 3 surrounding districts around KCMC. So first we'll talk briefly about the retrospective chart review. This was a pretty straightforward. We basically reviewed every adult admission at KCMC for a 6-month period spanning 2017 to 2018. And we just recorded everyone's admitting diagnosis. What were they admitted for? We reviewed 2,400 admissions, and we found that 12% of patients were admitted for heart failure, and 8% of admissions were for stroke. But only 9 out of 2,400 patients, or 0.3%, were admitted for MI. Heart failure and stroke were actually the 2 most, of all possible diagnoses that someone could be admitted to the hospital for, heart failure and stroke were the 2 most common diagnoses. And for every 1 MI admission, there were 33 heart failure admissions and 23 stroke admissions. So on the one hand, this suggests that there's a really high burden of cardiovascular disease in northern Tanzania. Just these 2 diagnoses, heart failure and stroke, accounted for more than 1 in 5 admissions. And to give you a sense of how unusual that is, in the United States, those 2 diagnoses account for about 5% of all adult admissions. So that's a lot of heart failure and a lot of stroke. But then MI was exceedingly rare, which is similar to what has been reported in other retrospective studies. And to put this in perspective, the ratio of MI to heart failure admissions at KCMC was 1 to 33, and in the US nationally that ratio is about 1 to 1.5. And the ratio of MI to stroke at KCMC is 1 to 23, whereas in the US this ratio is 1 to 1. In case you're wondering, the US is like most other places, these ratios are pretty similar across all other world regions, except for apparently KCMC. So this led us to wonder, is it possible that patient healthcare seeking behavior is explaining this absence of MI? Is it possible that patients just aren't coming to the hospital and that's why we're not seeing MI? So to answer that question, we conducted a community survey. This was a 2-stage randomized population-based cluster survey. Briefly, we just, in a population-weighted fashion, selected 60 random sub-districts and then 12 households within each sub-district, and we administered a survey to a self-identified healthcare decision maker for that household. And we asked them the following questions. Name all the causes you can think of chest pain in an adult. Name as many as you can think of. Where would you go if you or another adult in your household were to have chest pain? what are all the symptoms of a heart attack? Name all of them that you know. And do you think that you personally are at risk of a heart attack? We enrolled 718 respondents, the majority of whom were females. About a third of them had health insurance, and our median age was 48 years. These are all the causes of chest pain that our respondents could think of. And you can see that out of 718 participants, 2 or 0.3% thought heart attack might be a cause of chest pain in an adult. The most common responses were things like weather, exercise, cigarette smoking. Then we asked the question in another way. Tell me all the symptoms of a heart attack that you know. And when we asked it this way, only 3% of all participants thought chest pain might be a symptom of a heart attack. The majority of respondents, more than 50%, said they didn't know any symptoms of a heart attack. They couldn't think of one. And those who did identify a symptom or identified symptoms that most doctors would say are not typically associated with a heart attack, things like feeling sad or having a headache. So overall, only 16% of all of our respondents could identify any conventional MI symptom. And there was no association between ability to identify an MI symptom and any participant characteristics, such as their educational status, their age, whether or not they lived in an urban environment, which is to say that lack of knowledge of MI symptoms was prevalent across all subgroups. Only about a quarter of participants thought they had any chance of having a heart attack. And although older respondents appropriately thought they were at higher risk of a heart attack or were appropriately more likely to perceive themselves as being at risk of a heart attack, there was no other relationship between participant response, participant characteristics, and their perception of self-risk. In terms of where participants would go if they were to experience chest pain, the most common response was a hospital. This is appropriate in northern Tanzania because in northern Tanzania, the only facilities that have the capacity to test for a heart attack are hospitals. But the majority of respondents, about 62%, said they would go somewhere else, like a dispensary, they'd stay at home, they'd go to a pharmacist. Females were slightly less likely to prefer a hospital, but again, this lack of preference for a hospital was prevalent across all subgroups. So we had a lot to chew on as we thought through this data. This is actually the first study of perceptions of chest pain and healthcare-seeking behavior for chest pain in sub-Saharan Africa. And we found that in general, recognition of cardiovascular causes of chest pain was very low. And this is different. You can find lots of studies that have been done like this in every other world region, where the majority of respondents, when you ask them, what do you think some causes of chest pain in an adult are, can identify cardiac causes of chest pain. We also found that most adults would not present to a hospital for chest pain, and this is again different from other world regions. When you at least ask people, they say they would go to a hospital if they had chest pain. Only 16% of adults could name any conventional MI symptom, and this again was prevalent across all subgroups. Less than a third perceived themselves to be at risk of MI, again prevalent across all subgroups. And so we concluded that there is an urgent need for educational programming regarding MI symptoms, healthcare seeking, and personal risk in northern Tanzania. So we thought this might be the whole story that, well, we'll never know because they're not coming to hospital. But just in case, we decided to check. And so we proceeded with a prospective observational study in the emergency department at KCMC. And for about 4 months, or 5 months rather, all adults who came to the KCMC ED with chest pain or shortness of breath, we enrolled. So anyone who had a primary or secondary complaint of chest pain or shortness of breath was eligible for our study. We had very, very broad eligibility criteria. And we only excluded them if they reported they'd had a fever, if their chest pain was secondary to trauma, or if they were unable to provide informed consent. We administered a standardized questionnaire about their medical history, their history of present illness. We measured their weight, their height, their blood pressure. Mostly because of funding limitations, we allowed most of our definitions for medical comorbidities to be driven by patient self-report. So diabetes, hyperlipidemia, tobacco use, HIV infection were defined by patient self-report. For high blood pressure, it was self-reported history of high blood pressure or elevated blood pressure when we measured it. And then we used the National Health and Nutrition Examination Risk Score, which is this internationally validated risk score that uses a patient's age, whether or not they smoke, their blood pressure, their body mass index, and whether or not they have diabetes to calculate a 5-year risk of a cardiovascular event. So basically, you plug in a patient's data and it tells you what is the risk that this patient will have a cardiovascular event in the next 5 years. And then we just watched the patients. We just observed what happened to them. We observed their care, any testing they got, any treatments they got, and we recorded their diagnoses. And then we called them 30 days after enrollment to check in on them. So we screened about 4,000 adults, and of those we enrolled 339. So about 9% of patients had chest pain or shortness of breath, and overall of all the patients that we screened, about 6.7% had chest pain. And these are the characteristics of the participants that we enrolled. They were actually a very high-risk population. So 3/4 of them had hypertension, about half of them were overweight, and about 2/3 of them had a 5-year risk of cardiovascular event over 10%, something that we would call in the United States a high-risk patient. The vast majority of them reported that their symptoms were worse with exertion, which for those of you who are not clinical, that is suggestive that this could be a cardiac cause of their chest pain. Their median age was 60 years, and very depressingly, the median duration of symptoms prior to hospital presentation was 7 days, which means on average, patients had chest pain or shortness of breath for 7 days before they came to the KCMC emergency department. And this is what happened to them. So about half of them got an EKG, and less than 3% of them got cardiac biomarkers ordered. Almost none of them got aspirin. And in terms of their diagnoses, by far the most common diagnoses were symptomatic high blood pressure and heart failure. I had to cut out a lot of diagnoses to get MI to fit on this slide, but suffice it to say, less than 2% of patients were diagnosed with an MI. And we were trying to understand what is driving the physician to obtain an ECG. What is driving that decision? And we were not able to figure it out. So we couldn't find any association between decision to obtain an ECG and the patient's overall cardiovascular risk, their age, whether or not they had high blood pressure, whether or not they were obese, et cetera, et cetera. So this flow chart, which is kind of small, kind of summarizes the overall flow of patients through the emergency department. So you have 339 patients presenting with chest pain or shortness of breath. The figures that are gray represent high-risk patients, and the figures that are black represent low-risk patients. And you can see half of patients get no testing, and that includes a lot of high-risk patients, and of those, none of them are diagnosed with MI, and none of them are given aspirin. Just under half get an ECG only, and of those 2 are diagnosed with MI, and 1 is given aspirin. And then a lucky 9, which are not actually very high risk, get tested with both an ECG and a troponin, and of those, half are diagnosed with MI, and half of those get aspirin. So we spent a lot of time thinking about this data. This was one of the first studies of the management of chest pain in an emergency department in sub-Saharan Africa. And we were surprised to find a lot of patients with chest pain. And in fact, the prevalence of chest pain at KCMC is similar to what you would see in the United States, which was surprising to us since most adult Tanzanians apparently said they would not go to the hospital if they had chest pain, suggesting that there's maybe a large population of patients with these symptoms out in the community that we did not capture in our study. The median duration of illness was 7 days, which is really long. In the United States, the median duration of symptoms for patients who present with chest pain is about 2 hours. And if you look even in middle-income countries like India, Pakistan, always under 4 hours. So 7 days is really long. And the patient population that we found was really high risk, or at least high risk from the perspective of an American emergency physician. I would consider these patients very high risk. 3/4 of them had hypertension. Almost 2/3 of them had a greater than 10% 5-year risk of cardiovascular event. We probably are way underestimating their cardiovascular risk because we relied on patient self-report, so we relied on them to know that they had diabetes and high cholesterol, which most patients in Tanzania and elsewhere do not know. And we found that unfortunately, diagnostic workups for MI were not routine among these patients. Only half received an ECG, less than 3% got blood testing, and unfortunately, a lot of facilities, a lot of hospitals in sub-Saharan Africa and Tanzania don't have ECG or troponin testing. And so probably the overall testing rate in sub-Saharan Africa or Tanzania generally is probably even lower than what we found in our study. Similar to what's been reported elsewhere, we found that MI was a very rare diagnosis, but this is a little bit difficult to interpret since so few of the patients received the full diagnostic workup for MI. And so a part of me, when I saw this as from my American perspective, thought like, this is awful. All these patients should get ECGs, and at Duke, these patients would all get ECGs. But it's a little bit difficult to criticize for multiple reasons. Most importantly, we don't actually know how common MI is in Tanzania. So if it's not that common, maybe they don't need to be wasting limited healthcare resources on getting ECGs and troponins in every patient. So to try and understand exactly what was driving these physician behavior, we did a qualitative study. And we conducted in-depth interviews with 11 clinical officers and physicians who worked in outpatient departments, which are kind of like urgent cares, and emergency departments in and around Moshi. And we used purposive sampling to obtain a diversity of ages, medical training, work environments. We developed a semi-structured interview guide regarding barriers to MI care, and then we did face-to-face interviews with participants in Swahili. We conducted interviews until we had thematic saturation, and then a Tanzanian clinical officer and myself conducted a thematic analysis. We identified 9 dominant themes, and that all describe different barriers to MI care in Tanzania. 2 of those themes were provider-related, so all of the respondents felt that they did not have adequate training regarding MI care. They said they didn't feel like they'd really been taught adequately to interpret an ECG. They felt like their medical school education really emphasized things like malaria and HIV, and there was very little attention paid to MI. And then they also talked about this other thing, this poor application of their knowledge, that most of them knew that an MI would present with chest pain, but in the actual clinical context, there's this kind of failure to apply that knowledge to consider the diagnosis. And that's something that's very well described in emergency medicine literature kind of worldwide. And then they described a bunch of systems-related barriers. They talked, obviously, about the lack of diagnostic equipment. Not just that most facilities don't even have these testing, but the ECG machine is sometimes broken, or it takes a long time to get the results of the troponin test. They talked about cost of care, that for some patients the cost of these tests and treatments were prohibitive. And then they talked a lot about the lack of data. They said, I think MI is not that common here, but I don't really know, and without knowing how common it is, it's really difficult for me to know who I should be testing. And they also mentioned referral system challenges, so that if you're some patient in the village who has chest pain, you ultimately have to go through multiple levels of care and multiple referrals to get to a hospital where they can even test you for an MI. And finally, they talked about patient-related barriers. Doctors love to blame their patients, and they talked about patients not knowing a lot about MI, not knowing that they're supposed to come to the hospital if they have chest pain, and not being adherent to their medications. So we thought this study was, for me, really illuminating and kind of identified a lot of different actionable barriers to MI care in northern Tanzania, and suggested that we need to work to improve physician training, obtain some real burden of disease data, develop some locally relevant practice guidelines, expand diagnostic and treatment capacity, streamline the referral system, and educate the patients. And of course, there's a lot more qualitative work that needs to be done with other important stakeholders like the patients themselves, nurses, caretakers, administrators, etc. So then we moved on to phase 2, and this is where we actually tried to figure out how common heart attacks are. And so phase 2 was exactly like phase 1. We did the exact same thing. We continued to enroll all adults who presented with chest pain and shortness of breath. Except now, all patients that we enrolled, we underwent an ECG test when they arrived. And they also underwent a point-of-care troponin test. We used a tablet-based ECG for the ECG testing, and we used a donated Abbott iStat for the point-of-care troponin testing. We began this phase in January, and we're going to complete it in October in just about a month. For those of you who are interested, who are physicians, all of our ECGs were interpreted by 2 independent physician judges, and we defined STEMI per international guidelines, so pathologic ST elevation and contiguous leads. We defined NSTEMI as a positive troponin per guidelines. For those of you who are not clinicians, basically there's 2 kinds of MIs. There's STEMIs, which usually are caused by complete blockage of a blood vessel. It's sort of a massive heart attack, and we can detect that on just an ECG alone. And then there's NSTEMIs, which are usually caused by a partial blockage of a blood vessel, usually result in a smaller size of the heart that died, and that requires a blood test for diagnosis. And then we defined ischemia and prior infarct per international guidelines on the presence of pathologic T waves and contiguous leads and pathologic Q waves and contiguous leads. For the non-clinicians, basically this means even if you don't have a heart attack, we can see on the ECG evidence of stress. And when we see that, we call that ischemia. And we can also see on the ECG, even if you don't have a heart attack, we can see if you've had a heart attack in the past. and we call that prior MI or prior infarct. So as of August 28th, we had enrolled 583 patients in phase 2, and an astounding 22.8% of them had an MI, including 59 STEMIs and 74 NSTEMIs. So far, we've conducted our 30-day follow-up on 113 MI patients, and of those, 39% were dead within 30 days. This, I still can't believe it when I read this data. It is so shocking. So to compare phase 1 to phase 2, on the left side, you can see this is what happened when we just observed what happened, when testing was left to individual physician discretion. Of patients with chest pain and shortness of breath presenting to the emergency department, 2% of them were diagnosed with an MI, and the other 98% received some other diagnosis. And in 2019, when we conducted objective testing on every patient with these symptoms, we found that 23% of patients had a heart attack, 34% of patients additionally had evidence of some decreased blood flow to their heart, 8% of patients had evidence of a prior MI in their EKG, and only 35% of patients had a totally reassuring workup. So far it appears that MI is actually remarkably common in the KCMC emergency department. And to give you a sense of how shocking this 23% figure is, in the United States, patients who present with chest pain and the physician decides to do some kind of workup for an MI, only 5% of them have a positive ECG or troponin. So 23% is really high. If we had 23% of patients with chest pain in the Duke emergency department have an MI, the hospital would shut down. We don't have beds for that many patients. And moreover, our study methods are probably missing a lot of patients. Keep in mind, we're not capturing anyone who doesn't come to the hospital. And because the tests for MI are time sensitive, we're probably missing some late presenters. So if you come 1 to 2 weeks after your MI, your blood test and your ECG may be normal, or at least may not show an MI. And so we're probably missing those patients by our study methods. Comparing the rate of MI diagnosis in phase 1 and phase 2 suggests that more than 90% of MIs were missed when testing and diagnoses were directed by physician discretion, which is pretty horrifying. And then the most horrifying statistic of all is the 30-day mortality rate. So more than 1 in 3 patients were dead within 30 days of checking into the emergency department. And this, of course, does not account for all the patients who died before they came to KCMC. To give you a sense of how especially horrific that mortality rate is, this is a summary of the 30-day mortality rate following MI in a bunch of different countries across the world. And 39% is a huge outlier. In fact, you won't find 39% anywhere. You won't find 39% if you look at studies from the 50s in the United States where we had very little treatment options. So this is a really, really, really shocking and depressing mortality rate. So as we're processing these kind of surprising results, we're now thinking about what the future directions are. Where do we need to go from here? We need to complete phase 2. That's obviously a priority. And then we're going to use our community survey data we asked patients actually specifically, what specific facility would you go to if you had chest pain or shortness of breath? And we're going to use that data coupled with the address data of the MI patients that we detected at KCMC to estimate what the incidence of MI in Moshi region is. And so this will be exciting because this will be the first actual incidence calculation for MI in sub-Saharan Africa. And then we're going to have a cohort. We estimate about 150 patients with MI, and we're going to follow them for a year. We're going to try and understand when do they come back to the hospital, how do they get care, what barriers do they face, what medications are they put on, do they have trouble affording their medicines, etc. And then we want to measure the effect of what we did in phase 2 on physician behavior. So at the Duke Emergency Department, I don't have to think to get an EKG on a patient. It's protocolized. And this is true of most emergency departments worldwide. If you check into the Duke Emergency Department with chest pain, they don't have to grab a doctor to be like, do you think this patient needs an EKG? The triage nurse just orders it. It's just protocolized. And that's essentially what we did. If you checked into the KCMC emergency department and chest pain or shortness of breath was on your list of symptoms, you got an EKG and troponin. And so we want to see how that affected what the physicians did, how that affected whether or not they admitted patients, how that affected what diagnoses they gave patients, how that affected what treatments they gave patients. Because this is the kind of implementation work that was done in the States decades ago when they were trying to address this problem of missed MI. And then most importantly, we need to work with our collaborators in Tanzania to develop some rigorous interventions to improve MI diagnosis, care, and mortality. The next big phase of our study is Duke Center for AIDS Research Study, which will start in about November, and that's going to look at the burden of MI among patients with HIV. We know that in high-income settings, patients with HIV have approximately double the risk of MI. It's thought this is because the chronic infection with the virus causes chronic inflammation, which increases the risk of an MI. And in fact, we know that patients who have more poorly controlled HIV and higher viral loads have higher levels of inflammation and a higher risk of having an MI. And of course, nowhere in the world has a higher risk of a higher burden of HIV or a higher burden of poorly controlled HIV than sub-Saharan Africa. Unsurprisingly, there's no data about MI in persons living with HIV in sub-Saharan Africa. So that will be the next important phase of our study. We're going to try and quantify the burden of MI among HIV-infected adults. So in conclusion, in northern Tanzania, community recognition of MI symptoms is low, and a minority of adults would present to the hospital for chest pain. MI is a very rare clinical diagnosis relative to other cardiovascular diseases that share common risk factors. ED physicians rarely pursue complete diagnostic workups for MI, even in high-risk patients with concerning symptoms. Patient, provider, and health system factors likely contribute to MI underdiagnosis and suboptimal care in Tanzania. MI is common and carries a very high mortality rate in northern Tanzania. I want to acknowledge several people, the NIH Fogarty Center, which funded this study, and we definitely want to acknowledge Abbott Laboratories that donated the point-of-care troponin supplies for this study. And most importantly, we want to acknowledge our research team. This is Oscar, he's one of our research assistants. We did this whole study with 2 research assistants, and we want to thank the ED clinical staff and, of course, our patients. This slide is not included, but there are so many people who contributed to this study in one way or another, and I want to thank all of them. Many of them are in this room, but thank you to all of you who helped contribute to the study, and I apologize to those of you who I left off the slide. These are my references, and that's it. Thank you very much. I welcome you.
That's amazing work. I hesitate to congratulate someone for finding such a kind of shocking result, but that's really important work. Thank you for presenting that. One question about the surveys you did. I assume those were done in Swahili.
Mm-hmm.
And is the Swahili word for heart attack the same as our word for heart attack, or does it have connotations of heartache or heart sickness and more emotional kind of connotations?
Yeah, we had to do a lot of focus group work around that terminology. There is a term, and Godfrey can correct me, which means heart attack. It means heart attack, and we did a lot of work to mean, does that mean feeling sad, or does that mean your girlfriend broke up with you? And they're like, no, that means this thing that happens to your heart that you could die from, a sudden attack of the heart. Yeah.
Thank you.
You're welcome.
Julian, I think in the phase 1 you also did the follow-up
Mhm.
phone calls. What was the mortality rate amongst the patients in your phase 1 study?
Awesome question. I should have mentioned that. It was 8%. So in phase
Across
1,
the board.
all comers who have chest pain or shortness of breath, and we don't know which of them actually had an MI, the overall mortality is 8%. And in phase 2, the overall mortality for patients who didn't have an MI is about 8%. Yes, in the back.
Hey, forgive me for my ignorance, but can you tell me a little bit about what sort of specific cardiology training the doctors at KCMC receive, and how this study will inform, hopefully, some changes to that?
So great. The KCMC is staffed by a range of providers. So that includes kind of attending, supervising physicians who have trained specifically in emergency medicine, where you would get kind of really rigorous training in ECG and MI diagnosis. It includes supervising physicians who've just worked there a long time but haven't done formal residency training in emergency medicine, which is basically a brand new concept in Tanzania. And then it includes a bunch of trainees, registrars, interns, all of whom have gone to medical school. And if you ask someone who works at a medical school in Tanzania, they would say, yes, we teach this. This is certainly what someone would consider kind of med school 101. You would learn about EKGs and troponins and heart attacks in medical school. So in theory, the things that we were looking for, things that anyone who went to medical school should have done. But obviously, especially through our qualitative work, we identified kind of a lot of challenges. So we are continually feeding these results back to the KCMC leadership. And when we have a final result, we're going to share it with the Ministry of Health to see if that can not only spur changes at the medical school at KCMC, but maybe kind of nationwide.
Cool.
And I think you're seeing this across sub-Saharan Africa. Just like in the States, we're just kind of, education always lags behind epidemiology. And so I think most people now recognize maybe we need to find room for cardiovascular disease in the medical education. Dr. Thielman.
Yeah, so Julian, thank you again. Moving forward, assuming that you have all the diagnostic capacity in place, where is the low-hanging fruit for making a difference in protocolizing some interventions? You don't have a cath lab. There's certain things you're not going to have for a while. How can we make a difference next?
So in my mind, there's two low-hanging fruits. The first is improving diagnosis. So we're not going to fix the problem until we're actually diagnosing people with MI. And there are a lot of medications and treatments that are affordable that you can put someone on that can save lives, that don't involve a very expensive cath lab. So diagnosis, I think, is low-hanging fruit number one. The other really important low-hanging fruit is aspirin. So the WHO has these like best buys for cardiovascular disease worldwide, and they do all this modeling to say what are like the things that you should do that cost the least that will save the most lives. And on that list, which is not a long list, is giving aspirin to patients who have a heart attack because it is so cheap and it has such a strong mortality benefit. And so for those of you who aren't don't have a medical background, patients who have a heart attack should get an aspirin as soon as possible, and then they should be on an aspirin sort of indefinitely after that. And so that is a very, aspirin is widely available everywhere in sub-Saharan Africa. That's a very cheap, low-hanging fruit that I think would have a lot of impact on morbidity and mortality. Yes?
I'm curious to know what like the gender breakdown of the people who are coming in, just because I mean, even here in the US, there are all these studies coming out saying that women don't present the same as men for heart attacks, and now you're hearing this terminology of like a lady heart attack, which is ridiculous. But I get it in theory why we're calling it that. But and so I'm just curious, like when you think of what we're now learning in the US about what heart attacks look like in women, how does that translate to the work that you're doing there?
Yeah. Awesome question. So I think there's a lot of interesting things to say about sex and heart attacks. As you mentioned, in general, women are more likely to have atypical symptoms, which means not chest pain, not shortness of breath. They'll feel like nauseous or feel lightheaded potentially. Among men, about 90 to 95% of men will have either chest pain or shortness of breath. And among women, it's really only 75 to 80%. So women are more high risk for being missed, both by our study methods and just in general in hospitals. We also know that male sex is an independent risk factor for an MI. So even if you control for everything else, for some reason, men are more likely to have heart attacks than women. And there were so many interesting things in our study. When we asked the question, where would you go for a heart attack? Women were less likely to say that they would present. And you see that in lots of settings. Where you ask people, like, would you go to a hospital if you had chest pain? Women are less likely to say they would go to a hospital. But then actually, when you look in hospitals, there's way more women with chest pain in emergency departments, including in our study. Our population was more female. And almost all studies that have looked at chest pain in emergency departments have found that women actually do present more commonly. And so men are liars, basically. Men, if you didn't know, and this has been shown not just for MI. This is true in HIV. Men are just way less likely to seek care, to be engaged in their care. But when asked in a survey, men are much more likely to say that they would. So I think that so among our MI patients, it's about 60% men, which is similar to what you see in other settings. But I think we are certainly missing more women than we're missing men. So I think we could write like 8 papers just about sex, MI, and Tanzania because there's so many. It's so interesting to me how much, and this is true just in every setting. Men just love to lie. Other questions? Larry.
Yeah. Would you expect to see similar mortality rates in other parts of sub-Saharan Africa as you've seen in Moshi?
So I don't know, and so there are 2 studies that have reported a 30-day mortality rate for MI in sub-Saharan Africa. And both of those studies were retrospective. They were done at big private hospitals with a cath lab. And so they basically took their patients who got a cath and followed them for 30 days. and they both reported a 30-day mortality rate of about 8 to 10%. So I think if you're wealthy, you live in a major city, you have access to a cath lab, your mortality rate, and you get caught by the doctors, and you go to cath lab, your mortality rate is probably 8 to 10%, which is what you'd expect if you looked at kind of other similar income countries. To my knowledge, there's no other data about 30-day mortality rate prospectively in centers without cath labs, in centers that we're not asking the physicians to diagnose the patients with MI, we're diagnosing them. So unfortunately, I suspect that out in most parts of sub-Saharan Africa, the mortality rate looks closer to 39% than to 8%. Tanzania has a relatively weak health system, and so some countries with stronger health systems might perform better than Tanzania, but I'm not optimistic that we're an outlier. Melissa.
Well, this was great, and I just want to particularly commend you on kind of the program of research that you've developed, and it's a really great example of sort of the sequencing of studies to sort of build a research program. So I want to follow up on Chris's question about sort of some of the cultural idioms around hearts in general, I guess, because when you ask the question, sort of what are the primary causes of chest pains, other than don't know, the number one was worry or other things. And, and we've heard this, of course, also in hypertension and discussions like that hypertension comes from, it's pressure, right? It's this literal pressure and stress people feel. Do you think, what else have you heard and kind of understood about kind of discussions about like the origin of symptoms and whether people are sort of seeing kind of a clinical definition of heart attacks?
That's an awesome question. So my colleague Preeti Manavalan is doing a study of hypertension in Tanzania and has found the same kind of like people kind of equate hypertension with stress, with worries. And you see that in the United States, and it's not actually completely biomedically false. Like stress in general does increase your risk of both a heart attack and high blood pressure. Unfortunately, everyone has stress at times in their life, and most people at times in their life feel stressed. And by far, they're much more important predictors of MI or hypertension, like your genetics, whether or not you have high blood pressure, whether or not you have diabetes, that are unrelated to your day-to-day stress. Definitely in Tanzania, I think there's, I'm not Tanzanian, so Godfrey, or the other Tanzanians in the room, please correct me if I'm wrong. I think there's a strong community belief, especially with regards to cardiovascular disease, but in health in general, that psychological well-being and stress is a very important mediator and maybe even cause of cardiovascular disease in particular. You see that in the United States too. I can't tell you the number of times in the emergency department people are like, oh, did he have this heart attack because he just started his new job? No, that's not why. It's because his blood pressure's out of control. But people are very quick, I think, the world over, and maybe particularly in Tanzania, to ascribe psychosocial stress as an important cause of cardiovascular disease.
Did you hear that at all from providers?
So, no, the providers didn't say that they, in our study, the providers did not say that they thought the reason MIs were so common was because of stress. The providers in our study mostly said they didn't know how common they were, and they thought that the problem was that doctors, not themselves specifically, but other doctors didn't know what they were doing. It's kind of a summary. Janet.
I'm just wondering about translation. So you mentioned that people aren't necessarily going to the hospital, and not everybody's going to make it into a regional center like KCMC. So you likely know we started troponins in urgent care here at Duke, and I'm just wondering about the translation of this maybe to other settings outside of the emergency department so that more people could get access sooner.
Awesome. So when people came to the emergency department in our study, we asked them, like, where did you go? Like, what happened? Like, tell me everything that happened between the onset of your chest pain and you getting to the emergency department. And more than half of participants went somewhere else first. And most of those participants were told either to come to KCMC, or much more likely, they were told you have pneumonia, you have stress, you have high blood pressure, etc. You take some Tylenol. And so at the end of our study, we'd like to look back and look at the patients specifically who had MI and trace back their steps from onset of symptoms to their diagnosis in the emergency department. And I suspect we're going to find that the vast majority of them went to low-lying facilities like dispensaries and health centers, and those who had resources or those who had willpower or those who lived close to KCMC eventually came to the KCMC emergency department. So I think that's a really important point that, you can get an EKG at Duke Urgent Care now, you're going to get troponins, and almost every health facility these days has an EKG machine. If you're in your clinic appointment somewhere, there's an EKG machine in the back. If you develop chest pain, they're going to get an EKG. And so we're hopeful that in future research we can kind of do a little bit more implementation science work with these outlying facilities and understand what their processes look like, what's the feasibility of putting an EKG machine, which is kind of a one-time big expense and then very little expense after that. In these facilities and trying to understand, we use these tablet-based ECGs, which are not that expensive and are probably a much more feasible option in some rural facility than trying to get a big, bulky, 1960s style ECG machine. Any other questions?
You have answered it partly, but I would like first to congratulate you for amazing job, and it's striking to know that we have this burden of non-communicable diseases. I agree with you. Throughout our medical training, it was really focused on the burden of disease. Even during word round, and they ask you, which test will you do first? And if you mention something which is not even available, but it's a gold standard measure, they will look at you and say, you don't know what you're doing. So I completely agree that it really based on disease burden. But I was curious to know the proportion of the patients who came directly to KCMC and those who were referred from other facilities in your state.
Good question. That's one of the bad things about doing a study in a referral hospital. About half of our patients came from another facility, and most of those patients had been referred either formally with a letter or just verbally been you should go to KCMC. So we are not, only half of our patients, the KCMC emergency department is an emergency department, so anyone can come. You don't need a referral to come to the KCMC emergency department. But a lot of patients end up at KCMC because they're referred. And so our study population is probably slightly different than what you would see if you were at a local dispensary and we're just trying to enrolling people at their first point of contact. So we are getting about half of our MIs and about half of all our patients, their first point of contact was KCMC, but another half went somewhere else first. Charles.
Thanks for a great presentation. I'm just following up on that. And was there a difference in the outcomes for folks who self-referred versus those who had to be referred across the health system?
So I haven't done an analysis yet of all the predictors of mortality, but pretty much there's a signal for pretty much everything you'd expect. So patients who aren't on an aspirin after they go home are more likely to die. Patients who are older, patients who have more delayed presentation are more likely to die. And actually there's a strong signal for the patient's own knowledge of their diagnosis. So I didn't have time to present this, but we asked all our patients 30 days. We were like, what did they say was wrong with you? What was your diagnosis? And do you understand it? And do you understand your treatment? And the majority of patients are not able to provide their diagnosis. Most either say they don't know or they confidently provide a totally different diagnosis. Like I have malaria, the doctor said I have malaria. And the doctor's written down, heart attack. So there's a big problem around understanding diagnosis and understanding treatment. And actually that, understanding their diagnosis and their treatment, is strongly predictive of mortality in our population in general, regardless of their diagnosis, and among the MI patients, which is kind of amazing in a lot of ways, suggests that maybe an educational intervention would actually improve outcomes. But it's different than what you see in a lot of other places. There's a lot of effort, even if you look in the United States, patients don't always have great knowledge, and a patient's medical literacy has some impact on some kind of intermediate endpoints like medication adherence or other things, but it very rarely has been shown to actually affect hard endpoints like mortality. And so it may be that in a setting where there's kind of a weaker health system in general, the patient's own knowledge of the disease and their effort to navigate this healthcare system is predictive of mortality.
Is your tablet ECG, is that a 12 lead, and do you absolutely need a 12 lead, or could you get by with a little 2 lead like this, which I've used to send tracings to my cardiologist from Bangladesh and Vietnam and so forth.
It's a 12 lead, and I think cardiologists would say you truly need a 12 lead. A 2 lead is good for rhythms, but not great for looking at all parts of the heart to decide if there's an MI. You can easily miss an MI with a 2 lead ECG. Godfrey,
This is just a
keep them coming.
I know that I've seen when you present this kind of a result in a setting, people they get excited and then all of a sudden you see like overdiagnosis of MI. So how are you going to control that? I mean, like, let's say you go back to KSMC and present it to them and then
A lot of people
Yeah.
with costochondritis are being told they have an
An MI, yeah. So that's a separate problem and not one that we've had yet at KCMC. We're continuing to monitor the diagnoses that these patients are given. We haven't seen a lot of patients who we didn't think had an MI, but the physician documented a diagnosis of MI. That hasn't happened yet. Now, we are continually, all the results of our study we share immediately with the clinical team, and we're also continually providing them data about this, what we're seeing. And so I'm sure we're affecting what they're doing. But we haven't yet seen overdiagnosis. Now, it's only been, 9 months, so it's possible that overdiagnosis is gonna happen later, and that will be a separate issue. Charles?
I also think that it looks like he's got my cheat sheet. I think cost something on the radar that you're looking at in terms of just referring to that, so that overdiagnosis, just looking at the health system itself, that's gonna be, is that something in your radar? It's a separate problem, but
Yeah, no, cost is a huge problem, and I wish we didn't collect patients like income when we enrolled them, and I wonder, I don't know, if that was an important predictor when who the physicians were ordering the tests on. We haven't, I can say anecdotally, when we talked to physicians, they didn't describe that as a frequent problem, that they wanted to get an EKG and the patient refused it because they had to pay for it, because like most facilities in sub-Saharan Africa, if you don't have health insurance and the doctor wants an ECG, you first go pay for that ECG, you bring back your receipt, and then you get the ECG. Now, KCMC, if they really think someone needs it, they'll do it anyways, but that's kind of the standard operating procedure. So a big question is, in the US, we have this opposite problem where we're finding so few heart attacks that we're trying to find ways to be cost conscious and not over-order tests. I think any cardiologist would say, if 23% of the people you're testing have an MI, you're not testing enough. So our very broad protocol right now, I don't think is over-testing, but then it's also a question of what can the health system afford, and where do you put, I think most people would say the ECG is overall pretty cheap and pretty high impact in terms of potentially saving someone's life. But obviously there's a lot of different disease processes in Tanzania and a lot of different places to put money. And so that, this study really was not at all designed to be a cost effectiveness study, but that's going to need to happen. As we think about how many patients would you actually identify and how many of those would get on life-saving therapy, and how many lives would you be saving per dollar? We're not there yet. Well, thank you very much. I appreciate your attention and